It's so wonderful to see everyone today. I obviously want to have a one-on-one with all of you, with the entire group, and I'm not going to be able to do that today because we're here with Dr. Alan Eppel, and he is going to be sharing with us about the book that he's written called Short-Term Dynamic Psychotherapy. And what's wonderful about Alan is not only is this book of such an interest to me and other people in our community, but he's a really interesting person too. And I discovered that 2 weeks ago when I did the prep interview for this interview and found out so much about him that I'm excited to share with all of you. But to begin with, yeah, Alan is a psychiatrist at McMaster University in Hamilton, Ontario, Canada. Do I have that right?
Yep.
And he teaches psychiatry residents. And due to his work with psychiatry residents, when he discovered affect theory, and how to apply it, he also decided to write a book for his residents so that they could learn about experiential dynamic therapy too. And if you have a chance to purchase his book and read it, the three models that he pays most attention to is ISTDP with Alan Abbas. And just interrupt me, Alan, if I don't have this perfectly. Affect phobia therapy with Lee McCullough, and then accelerated experiential dynamic psychotherapy with Diana Fosha. And many, many more. And so if you get a chance to even pull up his book as we're in this interview together and just look at the table of contents, and you'll see the breadth of his work. I mean, he's looking at Edtronic's work, he's looking at a different attachment theory, and really kind of bringing everything together. So another thing about Alan is that not only is he a psychiatrist and he is dedicated to teaching residents and he's written this fantastic book, but he is also from Ireland. And Ireland is just really dear to my heart personally, but also for the affect phobia therapy, because we have been in alliance with Dr. Jonathan Egan, who is at the National University of Ireland in Galway. And he is not only trained with us in Stockholm, but he's also done a lot of research in affect phobia therapy. And I've been invited to teach in Ireland since 2010, and have always enjoyed my trips and have enjoyed the Irish people who said to me at one time, Alan, "It sounds really good, Kristin, but it won't work on the Irish."
That's right.
Yeah, and we did 2 role plays on stage, and there were tears falling, not only for the person in the role play, but for the audience itself. And that's when I said, it will work in Ireland. So Alan, thank you so much for joining us. We're really excited to have you here. And I'm just wondering if there's anything more that you'd like to tell us about yourself as a psychiatrist, a person, you know. So,
Not yet, but I can tell a little bit about how I ended up in the field of short-term psychodynamic psychotherapies. And it really started when I was a psychiatry resident in 1976, when there was a big conference in Montreal. And this was quite unique because Davenlou was there, David Mallon was there, Peter Sifnius was there, and other people. And what was also very unique is this was the first time for us anyway, actually seeing videos of what people really do. You know, we all know that what we think we do and what we actually do is often quite different. So as you all are well aware now, but it was quite revolutionary. The use of video, then you can really see what you're doing and correct it, right? So that was mind-blowing, and Davenlou was extremely controversial by his approach because it was just shocking compared to anything. I mean, this was a period when psychoanalysis was psychoanalysis. You know, anything that was deviating from that was just not really accepted in that field. So many years later, I came back to McMaster and I was asked to supervise psychiatry residents. So here in Canada, the psychiatric residents get some training in psychodynamic, CBT, emotion focused, and interpersonal. And I said, well, I think I need to update my training. And I thought I would try and get a video of Davenlu. And I Googled Davenlu, can't get a video of Davenlu. You know, it's some of you may know that, you know, it's pretty much like trying to get into Fort Knox unless you join the whole thing and put in all the time and training. But what came up was this woman, Diana Fosha. So I ordered her video and I watched it and said, what's this? Couldn't make head nor tail. I said, this is very strange. And then I watched it again. And I watched it again. I said, this is brilliant because it's totally different from what we're doing. At the time, my training had been much more focused on interpretation. Affect, coming from Ireland, really didn't exist. In Ireland, we didn't express it, much like Great Britain, you know, affect, other than anger, which was acceptable, but any other emotions at that time, it's changed a lot, any other emotions like tenderness, sensitivity, love, was not really expressed, and even other affects were only expressed with several bottles of Guinness as a pharmacological approach to releasing affect. So I was very inhibited and avoidant to my style, and that fit well with the training, which was mostly interpretive. And then I saw Diana Fosha's tape. I ended up doing an immersion course, and I did some training. And I realized affect is where it's at. And as I mentioned to Kristin, I did some individual, not individual, group supervision for a year with Eileen Russell in New York. And one of the most thrilling things about that was her office is beside the Empire State Building. And as a little kid in Ireland, I used to read the Dell comics, and it was all, you know, the US seemed quite attractive at that time. I'm not going to comment at the present time, but and the back of the Dell comics, by the way, had all advertising for BB guns, which, you know, that was, you know, we were getting indoctrinated as kids in another country. But anyway, that's another big story. But I realized the affect, and so I loosened up a bit. And as I told Kristin the other night when she was doing the initial assessment to see if I was suitable to come on to her therapeutic hour, she did a very thorough assessment. And got through a lot of stuff, personal stuff, very quickly. The power of the affect probing therapist. Anyway, I loosened up, and coming from the British Isles, I always used to wear a jacket and tie going to work for all my life. And then after ADP, I was able to get rid of the tie. I was so much more, the defenses a little bit were down, not all of them. But certainly the tie, the protective tie that defends you, I was able to get rid of. So I'm not completely there, but I've come a long way. And it's all through affect. The other thing is, I'll say I'm a better teacher than a therapist, probably. It's a lot easier when you have good residents and you're looking at the video and say, now, you know, what alternatives were going through your mind at that point, you know. And so I consider myself improved, but not great as a therapist. But teaching residents, I wanted to put it down in a way that was, I like succinctness, shortness, and that's actually, I would say, an Irish teaching trait, keep things short and focused. So I wrote a little manual, just like 20 pages for the residents, doing the main components of dynamic experiential types of therapy. And then I said, well, maybe we should make this into a book. To get the manual published, I had to write a whole book then. So that's how the book developed. But chapter 7 of the book is actually the manual. Basically, it's the how-to. But to get that published, I had to write the whole book, which is fine. And the other thing I wanted to achieve was the elimination of unnecessary jargon. Our program, although very short, and it's not psychoanalytic, it's psychodynamic, in teaching residents, always started off with the history, Freud, Melanie Klein, all this stuff, which is fascinating if you're a full-time psychotherapist and you know the concepts are beautiful, and somebody like Winnicott, who's almost poetic in the way he writes, and reading their case histories, even Bowlby when he talks about cases. But you can't pack in all these theories plus self-psychology with its horrendous terminology, no offense to anybody. So I just want to put it down in English and to translate psychodynamic theory into modern language. That was another goal. Because the residents were always confused. They'd come out of these training and they'd come then for their supervision, and really it wasn't that relevant to the actual practice. I think once you've practiced, then the theory, you can go back and pick some gems out of a lot of the theory and look at the evolution. ADP opened window to me. Then I learned about AFP, and I bought the AFP books, and I had Lee McCullough's video. And again, very interesting model. And I could see the common elements, even though the theoretical frame is conceptualized a little bit differently. And then in Canada, as most of you probably know, Alan Abbas is the main proponent of ISTDP. And I have seen him a few times at workshops and so on. And I said, you know, all of these models are good, but some of the terminology is a little archaic or a little confusing, or in some case, some of the terminology is too new. It's inventing new words for things where we already have words. So that's what I wanted to do. I wanted to extract the common elements of dynamic therapy, and in particular of the three main short-term dynamic therapies that I was aware of, which was affect phobia therapy, AEDP, and ISTDP. And so I wrote my book, and I didn't follow any pure model. I tried to extract the common elements, which I don't know if you want to break for any questions now, or do you want me to just keep rambling?
Personally, Alan, I'm enjoying listening to you, but does anyone have a question at this moment? I did take a moment and look at chapter 7, the manual, and is it okay if I just briefly say what's in it? So this might kind of jog everyone's creative juices. I mean, you talk about assessment and engagement, just lovely, being able to assess the patient, overall objectives in the engagement process, initial tasks, objective to take in the history, task associated with that, task associated with eliciting the psychodynamic history. So for most of us, that would be like working on the triangle of person, right? How do you begin to fill that out initially? A relational focus, a look at attachment style, diagnostic considerations, the office contract and orientation, a description to the therapy, emotion processing, defenses. So it's you go into the basics of defenses, triangle of person, formulation. And I have to say, Alan, with all the different therapists that we've had, whether they were ISTDP, AEDP, APT, that core conflict formulation is something that everyone really does focus in on a lot. And so it's lovely to see that in your chapter 7. And then a hierarchy of action. Sounds like a decision tree, Alan. And then finally, like the termination process. So that's a lot to fit into one chapter.
Yeah, I always had that problem with publishers, because I'm too short, they want more pages, but that's not my style. So, right, so the basic processes of dynamic, are those engagement and attaching. Now, the use of attachment language, so I said, okay, a lot of the new schools are using attachment language. So I said, attachment language is a bit more empirically based, and it's certainly useful. And I've tried at one point to translate some of the old terms into attachment language on the basis that it's easier to understand and has a more empirical foundation. I mean, there are literally thousands and thousands of articles written on attachment theory empirically, so it's a wonderful source of information, and also neuroscience. Now, there is a whole discussion. Is attachment model, which we use, is it really the same in therapy as it is in childhood attachment, or is it just analogous? Is it just a similar kind of process? Doesn't matter a great deal because it's a useful model. Whether it is very similar to what happens between the mother and the infant is, a lot of it depends on the measures, and there are only two real fundamental gold standard measures of attachment: the AAI and the strange situation. And the AAI takes a lot of training, and it's copyrighted, and it's difficult, so it's not practical for clinicians like myself to use or to be trained in. And the strange situation is for children. So the attachment literature, those are the only two, but there are literally thousands of other measures. So you don't know, are these measures really measuring the same thing? So that's one of the pitfalls of attachment. But as a heuristic, as an explanatory model, and as a guide, it's very useful. And going back to Bowlby, who says the relationship is setting up a secure base. So that's a very good metaphor, or maybe it is repeating what actually happens in childhood. We're revoking that secure base that we had or didn't have in childhood. So using the attachment language as an analogy or as another way of translating concepts is possibly a way forward, because I think in teaching, maybe we should start there with the attachment model rather than starting with the psychodynamic model, and add on the dynamic theories after you've grasped the more scientific approach. And that may be more acceptable, if you like, in the current climate, because we're looking to the future, and we all are aware of where is the future of psychodynamic therapies. It depends on your healthcare system, and it's very different in the US to Canada, to Europe, to the UK.
Alan, can I say something I just want to share with you? I mean, Lee was diagnosed with ALS in 2010. And at the time, I was in Amsterdam when I heard about her diagnosis. And then I flew out to Vancouver for the IEDTA conference. And she wanted me to present her case, The Machine Builder. And what she said was exactly what you just said. She said, if I could go back in time and rewrite my books, I would start with the attachment with, an APT, the self-restructuring and self-other restructuring. And so I thought you'd appreciate that. I mean, those were like, her last words. Yeah.
Yeah, yeah, that's amazing. I think for sure, as I've said before, you can go to university to study English literature, maybe even Swedish and Norwegian literature, and you might want to learn Latin and Greek to give you a deeper understanding. But you don't have to learn Latin and Greek. And we don't actually have to learn conflict theory or object relations theory if we don't want to. If we want to, it's very interesting to see how things have evolved. But if you're a young student, a resident, a psychology resident, social work student, it may not be that helpful to get bogged down in what's an object, what's a self-object, and all these words, when you can talk about it in attachment language. I like to make the analogy um, to geometry and algebra. I don't know if anybody's old enough to have studied geometry, the Pythagoras theorem of the square on the hypotenuse, with a big diagram of a triangle and a very complicated proof. Then you come to algebra, and it's very simple. A squared plus B squared equals C squared. You can translate the whole language of geometry into algebra, and it's much more. So I like to think that Freudian psychoanalytic theory and object relations can be translated into attachment theory, which is easier to comprehend. Anyway, so I think that's nearly everybody's jumping on the attachment bandwagon, including, I guess, the analysts, the strict analysts, in terms of relational theory, which is not quite the same thing. And I'm not an expert, so I'm ready to be corrected on this. But my little knowledge of it is that relational theory basically is using relational and attachment principles, but they have to put it in the language of Greek and Latin to have it accepted. So it's still using a lot of obscure and very complicated concepts to incorporate it. They're adding it on to an existing model, which is more complicated.
Alan, it's so interesting. I don't know if you've seen Ed Tronic's book, The Power of Discord.
No, I haven't.
He was at the IADTA conference in Boston before COVID, and he was the keynote speaker. And what's so interesting about this book is, of course, he's saying that, when there's ruptures in the relationship, that's when the capacity, for closeness increases. Like, can you repair? And that really brings to mind, for me as a psychotherapist, when patients become resistant, right? In the process, and can the therapist kind of hold in the process of repairing the rupture and repairing, the attachment issues too.
Absolutely. And I think rupture and repair is one of the most powerful interventions. Some people on the call may have done research into this, but rupture and repair, I don't know if Seinfeld was big in Europe or Scandinavia, but in Seinfeld's comedy show, they talk about makeup sex. When there's a rupture between husband and wife, the repair is very powerful and can improve the relationship. And that's Tronic's work. There's a disconnect between, or miscoordination between the infant and the primary attachment figure. And the repair, though, leads to resilience.
Right.
It's the repair that increases resilience. And in psychotherapy, too, if there's a rupture and you repair it, it's very therapeutic. So that's one of, I would say, one of the top relational interventions. Now, when I say that, it's interesting to think that there are common interventions, not just across dynamic therapies, but in cognitive therapies. And what popped into my head just now was therapy interfering behaviors, which comes from DBT, dialectical behavior therapy, which is if there is something getting in the way of the therapeutic process, such as cutting or suicide attempts, that has to be addressed before you can go any further. So it's an analogous. Another interesting analogous concept, I work in a clinic where most of the psychologists are practicing cognitive behavior therapy. And it's interesting, some of my psychodynamic colleagues feel that cognitive therapy is sort of taking over many of our concepts. It's kind of like it's an incursion over the border, and they're taking it. So they have different words, like core beliefs is really very similar to core feelings, and schema therapy was actually developed by a psychodynamically trained person, young, but is now considered part of CBT, stuff like this. But they are getting more into feelings. It's creeping in cognitive processing therapy, and but I was surprised at the overlap. So when we talk about portrayals as a fantastic way of mobilizing affect, in cognitive therapy they talk about imaginal rescripting, which sounds very sophisticated, but basically you're using visual imagination and you're changing the script, which is what you're doing really in a portrayal. You're eliciting intense emotions about a scene that's remembered, and you're changing that scene, and then the memories get stored in a new form, the reconsolidation process. And the cognitive therapists use that also for dreams, changing the dream by describing the dream and then, I guess, repeating it in the presence of a therapist who brings different perspectives or makes different attachments, connections to it, brings about a change of the narrative. I mean, Freudianism was the first narrative therapy. The narrative was from Greek mythology and maybe totally irrelevant, but it was used as the explanation. So there's the Woody Allen film where his mother brings him to see a psychoanalyst. He's 8 years of age, and his mother's concerned. They live in Brooklyn, and Woody Allen, as a child in the movie, is worrying about the universe. As the universe is expanding, the universe, he's ruminating about this, and his mother saying, "What business is of it for you if the universe is expanding?" And the analyst comes and said, "He's perfectly normal. He wants to kill you, his mother, and have sex with his father, so you have nothing to worry about." So that was the narrative explanation, which we don't think is very useful anymore, but it didn't matter. It was a different conceptual model that gave the patient something to understand. And even going back to Jerome Frank, famous paper of the common ingredients in all therapies, one is establishing an emotional connection, a relationship. Another is having some conceptual theory, some kind of an explanation, so that the patient has some sense of what it means. Now, the theory is more important for the therapist than for the patient, but nevertheless, we need something to keep us going. And
so Alan, I don't mean to interrupt, but I'm thinking about the psychiatry residents that you train, and I know Joshua Pretsky is here from UCLA, and Liz Alfson, and I'm assuming there's other people who are training residents that are in this hour with us. Like, what do you think are the three most important aspects of this type of work when you're training residents? Like what?
So the learning how important affect is, and that this is the most central issue in terms of healing. And I will use Diana Foch's definition of that the experience of deep affect in the presence of a therapist to whom you are securely attached is the leading change process. And that's quite different from the old interpretive models. And all of the therapies that we're talking about, affect phobia therapy, which it does it in a much more very explicit way with a different conceptual model, but it's the same process. Essentially, we're getting to deep and painful affect, and we're bringing it out and we're staying with it and we're somehow changing it or neutralizing it so it's not so painful and they're not so phobic about it. And ISTP does something similar, although in a much more complicated language. And I think it takes much longer to master that because it is a model that sticks to its language. But I think it is the same analogous process of getting to deep affect and what Davenlu calls unlocking the unconscious, I think is the same as Foch's getting to core affect.
So for you, Alan, curiosity, just being Irish and coming from a culture where like the only emotion that's acceptable is anger, right? On the surface. Like
Yes.
what has that been like for you to like really understand like the power of affect and its
It's revolutionary. And
yeah, can you say more about that?
you can apply it not just to psychotherapy, you can apply it to all your therapeutic encounters. So if I'm working with psychiatric patients with depression or bipolar, you've got the illness, but you've also got the person. So you can use some of the same processes, to find out how they're feeling about their illness, um, or even medical illness. What does it feel like to be struggling with this illness? And then what does it mean if you prescribe a medication even? Because that creates issues in the relationship. It can either be perceived as being brushed off. I had two patients years ago, both with a diagnosis of so-called borderline personality. One patient got mad at me because I wouldn't prescribe medication. He said, you don't care about me. You're just not interested. You won't even prescribe me medication. And then another patient said, I did prescribe medication. And she said, you don't care about me. You're just brushing me off with medication. So two people, two different interventions, which meant something very different in each individual relation. So understanding the interaction and the meaning, how the self is perceived or felt, and how the object is perceived or the other person is perceived, how they perceive you and how you perceive them. And that depends on our early developmental attachment relationships. So that's another major core issue, that the present, our expectations about current relationships is derived from particularly the early attachment relationships. And
So
in attachment language, we call that internal working models as opposed to internalized objects and so on. So your internalized working model affects how you expect others to respond to you.
So I'm stretching this just and this is what I'm hearing you say is that when people are able to experience affect with one another, it allows them to become more open and vulnerable about their perspectives with one another, like the perspectives that they have of themselves and the perspective
Yes.
they have of you.
I think you're leading the witness, but you said much more than I have. So that's, I would agree with you. Absolutely.
I'm following you, and I am thinking about the Irish as
I'm
well.
humble. I'll accept your input.
So, but it does speak to how therapists really have to have a deep knowledge of art, literature, Greek mythology, because when the affect is accessed, there is, the unconscious becomes alive. And yeah.
Yeah, and I think training in these therapies does change you. That's why I was able, as I say, to take off my tie. I still have my jacket on today for protection, but because I'm meeting with a strange audience. But maybe next time I won't. But yeah, it does change you, but which is fine because you learn about your own emotional responses, so you need to be aware of them in any dynamic training.
Just so you know, Alan, I want to offer you an invitation to come back because I actually would like to invite the audience and others to read your book, and then for us to have another therapist hour where we walk our way through it. And so
Well,
I'm hoping that you'll accept that invitation.
and you don't work for the publisher.
Nope.
Well, I would like to get some feedback how people respond to this, because there are people here who actually have more training and more knowledge than I do, and there are people who have probably done some research. So if the audience feels that will be
Well,
useful,
I do have one question that's on the chat, and then
yeah,
so I'm speaking for this
yeah.
person, and I know you know the answer. It's Richard. Uh, and Richard was asking, where does EFT fit in? And I know in affect phobia therapy, EFT is like a foundational aspect of affect phobia therapy. But you might know more than I do. So that's one question from the chat. Yeah.
Well, to me, EFT, a lot of it is just a subset of dynamic. So if you draw the Venn diagram, you can put a little circle inside, maybe a little bit over the edge, a smaller circle, and that's EFT. EFT grew out of Rogerian, client-centered therapy, and out of Gestalt. And Greenberg in Toronto develop it, and they've done a lot of empirical research to support their model. The way they talk about affect, they have different meanings. Like each model's, like DBT has another way of classifying affect, so it's a little not directly comparable. But the techniques of eliciting affect and staying with affect is very helpful, because in our program, the residents have done some EFT. So by the time they come to psychodynamic training, they're able to identify affect and explore it. So it's useful that way. But to me, it obviously dynamic therapies have much more in the larger circle. A lot more, we're dealing with defenses explicitly. We're using the relationship more. We're using our own responses to give us a better understanding. So it's a subset. I would also think that interpersonal psychotherapy, which was developed really as a treatment for major depression in the States by Gerald Clareman, also is a subset of dynamic therapy, although both EFT and interpersonal therapy have a few techniques that we don't officially include, but we can incorporate them into dynamics. So EFT uses the empty chair, which really comes from Gestalt and psychodrama, which is another way of doing a portrayal. It's acting out a portrayal is one way of looking at it. So it's a betrayal in space as opposed to a betrayal in imagination. And IPT has some other ways, interesting ways of sort of eliciting the problems and classifying the problems. But in many ways, to me, dynamic goes beyond both of those. And I'm not sure if you're trained in short-term dynamic, why you would use IPT or EFT as a standalone modality. Yeah.
And I'll tell you, Alan, so I had the privilege of being at a SEPI conference. I think it was in Baltimore, and on stage was Les Greenberg and Marv Goldfried having a conversation about affects, because Marv Goldfried, CBT, third wave affect, and Les
Yeah.
Greenberg, 3 decades of
Yeah.
research. And it was, I mean, I get chills remembering this interview. It was just so personal about what it was like for Les to be leading the charge on affects for 30 years without a lot of support. And then, when David Barlow published his paper in 2010, the third wave really, kind of came to life in CBT, and also all the funding that came along with it because it was CBT. And I've started to think of Les Greenberg as like our Sylvan Tompkins, right?
Okay.
Like, an affect theorist who's
Yes.
been out there researching affect and just really kind of looking at all the different, I guess, perspectives. And that's helped me out a lot, because I know people like Lee McCullough studied with Les Greenberg, Jeff Magnavita studied with Les Greenberg, and this goes way back in time. And you know, even as I was brought up in short-term dynamic psychotherapy to like really focus on anger and rage,
Hmm.
I've discovered over time my capacity to hold what APT would have called maladaptive affects is really, really important. And EFT does that so well, just kind of accepting when emotion is
Yes.
coming in the room and being with it. So I'm just offering that to you, because that's where I categorize Les Greenberg these days.
So do you feel that his techniques have been incorporated into the STTP models pretty well?
I think his you know, theory and his techniques, I think it depends on the therapist. Like, I mean, have I used the empty chair technique? Yes, awkwardly. It doesn't really work for me.
Mm.
But I have students who are masters at it,
Yeah,
and there's no getting around it. It really, really works. And so I found it depends on the therapist in terms of the techniques. But I mean, you know, his contribution I know has just affected so many people in positive ways.
thanks. Yeah, because you have the history that I didn't have. And certainly, I'm sure for affect phobia therapy, which seems to make use of that.
Yeah, I had good ears a long time ago, and I was at a lot of tables listening intently. So
Yeah, yeah.
so but I know there's more questions from the audience, and there's some in the chat, and people can feel free to ask out loud too. But if somebody has something they want to ask out loud, I'll look for a question in the chat.
Yeah. Okay. Somebody has asked about synthesizing or integrating cognitive therapy and dynamic. I think there's potential, and of course the whole journal of psychotherapy integration and the whole movement of psychotherapy integration is, I think it's quite feasible. Um, Although I'm not sure if we can really mix everything. There's there's a psychologist in our clinic who was one of the top cognitive therapists, and her specialty is in obsessive compulsive disorder, which is very tough to treat with any modality. But she is one of the warmest and most engaging people that we have in our clinic. She smiles. You can just talk to her for a few minutes in the hallway and you feel uplifted. So I always tease her and say, you think you're doing cognitive therapy, but it's the relationship that's really therapeutic here. You know, you're just therapeutic as a person. Your style and your affect and your engagement and your focus on the other person is so on target. And she kind of says, "Yeah, well, I could have done some psychodynamic, but I didn't." So she's so it, yes. I mean, what's really happening, and this goes to the common elements and the specific elements, the big debate. You know, what is therapeutic? Is it the common elements in the dynamic therapies, and is it the common elements in CBT? It turns out, I think, in CBT, there's a lot more non-specific relational elements that are not fully talked about. They're getting into that now, more realizing that. I mean, I was at a discussion with a group of our psychologists recently about the cognitive therapy paper, and the question was, does the personality of the therapist affect the therapy? Well, of course, but this is a new thing. And to us, that's fundamental, going back to Freud. I mean, that's more than 100 years old. But in CBT, that hasn't been, it appears, much of a thought. You know, that your personality and your style might actually change the situation. Um, and also in the attachment literature, there's a lot of studies on the therapist's attachment style and if it's complementary to the patient's attachment style. So looking at our own attachment styles and which patients we do well with, that's another whole area. So yeah, I'm not completely sure if you can integrate everything. I also find, as many of you probably do, CBT is boring, so that's why I do dynamic therapy.
uh, so there's one question in the chat, and I know this is the toughest question, and you probably ought to say, read my book, but it's, what are the differences and similarities of the three models? So,
Which
and
two?
yes, we will read your book.
Which two models?
Of the three models,
Oh,
ISTP.
the three models. Well, I think they're all, the language is different. The fundamental processes of establishing a therapeutic alliance relationship is common. The use of relational interventions is common across. The deep attention to signals coming from the patient to help guide your intervention, which is very unique actually. Now they use different signals, different kinds of, Diana Foster has traffic light signals, red, green, and amber. Davenlu has the sympathetic, striated, and cognitive dissolution, which is interesting. And then I think in affect phobia therapy, you've also tried to use some scales, accessibility, and congruence. So these are all great ways, because to try and objectify that in a way that can be taught. And that was another object of my book, was to try and make psychodynamic therapy teachable, because when I was training, I looked at the skilled therapists and they did amazing things, but they couldn't explain how they did it. Because by that stage it was intuitive and it was unconscious. They couldn't translate, well, what I'm doing here is I'm reacting to the affect. They didn't have the words. So that's why I came up with this, or I borrowed the model of choice point analysis and action alternatives to help students decide which is the best intervention at this second in the interview. And choice point analysis is a very useful way of, you look at the alternatives. Do you go after affect? Do you go after relation? Do you do rupture and repair? What do you do at any moment? And that's what the students had trouble with. We do it now instinctively almost, although we're monitoring the impact of our interventions. But for the beginning student, they're at sea in my experience. And there's a bit of a hierarchy. It's not complete or validated, but at the top of the hierarchy is rupture and repair. Because if you don't fix that, it's game over. Right. And it's also very powerful if you do fix it. So that's when it's necessary. That's at the top of the hierarchy. Anything that has to do with the relational interaction comes high up.
Alan, I'm kind of tracking you. So I have affect and I have rupture and repair, and I'm looking for a third when you're working with psychiatry residents. Like what?
So I would put, in terms of the actual process of therapy, or there's two different things there. Learning the therapy is learning about the central role of affect. And the moment-to-moment tracking.
Right.
Watching the other person's face, body posture, defenses to help you figure out where to go or what to say.
Well, and I'm remembering Ferruccio Osimo, who I don't know if you know him. He's from Italy. He was a founder of the IADTA. He would also say, mirroring back to the patient what you're noticing, like increasing their awareness of what's happening.
That's a good one.
Yeah.
Another very powerful one is meta-processing.
Yeah.
Which I think, again, is one of the top interventions. It's a sophisticated intervention, which you can use outside of psychotherapy. You can use it in other therapeutic relationships and medicine or whatever else. But meta-processing is reflecting on what has happened in the interaction between you and the person, or also determining what is the response to your intervention, how was it received, is a very important. So these are just a few
Tracking,
critical.
rupture and repair, meta processing. We have
Yeah,
4. Yeah.
yeah. Those are some of my top ones.
Can I ask one more question?
You're the boss here, so you can.
Okay, psychiatry resident anxiety. I mean, when I'm working with residents, they're so bright, they're so capable, they're so intuitive too. I mean, they're really, really good therapists, but they get so anxious about whether or not they're doing it the right way, or if the patient likes them. And so what do you do as a seasoned, like, master a trainer of residents? How do you help them with their anxiety?
That's the relationship with me and them. So again, if you like, the parallel process. So I have to model, something of acceptance and understanding. I find it's mostly at the beginning when they start, they say, they've done the seminars, but they say, I have no idea what I'm supposed to do. Um, and my first psychodynamic supervisor, when I was a resident, said, well, your parents brought you up well, so you should know how to relate to people. Just do what you were brought up to do. Be polite, be respectful, treat people with dignity, and so on. So, but once they get into 1 or 2 sessions, we go through the videos, I find it's like when you're learning to swim. When you jump into the water, it's very frightening. But once you start making a few strokes and you start to move, the anxiety comes down. That's my experience. Yeah.
Alan, as we begin to wrap up this hour, like, are you happy that you went into this field and you've discovered like affect for yourself, for your residents, and you've written this book and you're working with, I mean,
I'm delighted. Yeah.
yeah, you and your
I
work.
mean, I joke with other people that, my job is talking to people and I get paid for it. It's a pretty nice job. Yeah, no, I've been doing this for a long time, psychiatry for, and throughout my psychiatry, I've done some psychotherapy, but I wasn't trained as well as I've been trained in recent years with the new approaches. And I still look forward to going into work, which is a bit of a problem, you might say. Or as somebody said, if you're retiring from work to spend more time with your family, you better check it out with your family first.
Yeah.
That was on a comedy show.
Yeah.
Don't make assumptions, but I enjoy work. I do enjoy my family too, but I'm still addicted to my work.
And do you have any words of advice for those of us who love our work and have family and friends? Like, what if you could go back in time and somebody would give you this piece of advice? What
Well,
would?
as an Irishman, it wouldn't work. The advice is work-life balance. I'm not, yeah, I can't say that I'm best at that. I should spend more time with the family. I used to joke with my wife, and this is a joke, so not completely true. Um, I said, you can't blame me for how the kids turned out because I had nothing to do with their upbringing. It's not really true, but that was, the upbringing. You need to spend time with your kids, absolutely. And I did go to T-ball and all that, but the kids don't remember that we were there. Yeah, we did go to the sports and the baseball games, but they don't remember being there with all these things. But anyway, but that's a problem with professionalism, and physicians in particular, the absent physician. You know, doctors that come in on Saturday and Sunday when they don't have to, and they work long and they're very rarely home. It's driven by anxiety too. A lot of it is driven by anxiety, the need to be on top of things and be in control of your patients and so forth. I would love to hear people's voices before, if we have time. Oh,
So
we're pretty well out of time, I
let's
guess.
open it up to voices. No more chats. Open up to voices, and it is 2 minutes left. So if you have to leave, you have to leave. But if you want to stay, please stay.
Did you put the name of your book in the chat, or?
Yes, Lori put it in
I would
the
like
chat.
to read your. I'd like to read your book.
If you're part of a university, if you're on faculty, you may be, if you want, you may be able to download a PDF or an ebook for free.
I'm not. I'm in Denmark and I'm in a private practice, so I don't think I. Maybe
Okay.
I
don't know.
Have Lori send that out. If you're
Yes.
okay with that, Alan,
Good.
are you okay with that?
Yes.
Yeah.
I can't endorse it because of copyright, but
I didn't hear anything from you.
yeah.
Thank you.
Okay, thank you. Thank you. It's very interesting.
Good. Yeah, a lot of the great work has come out of Scandinavia about transference and whether transference is useful, or under what conditions, and the interacting factors. So some amazing work has come out of Norway and Sweden, also Holland.
Yeah, I'm from Denmark.
Yeah.
Yeah, sorry.
Well,
sorry.
it's a beautiful country.
Yes, it is. Okay. Yeah. Thank you.
Can I pose a question?
Yeah, sure.
I'm wondering, Alan, I see a large contingent from Europe. I'm in Los Angeles, and so I work with a large population of Latinos and African Americans in an outpatient sort of mental health setting. And I did get your book, or I downloaded. I'm a professor at USC. And I notice in these various sort of iterations of sort of affect theory and the models of psychotherapy, there's very little sort of discussion in regards to culture, in regards to sort of marginalized populations. And I'm wondering, is this just something that's beginning to sort of develop? Your thoughts on sort of culture? Is it, do you see sort of this affect theory as universal, that has no connection with culture? I'm just curious, these models, and working with an African American in Brooklyn to a Latino in Los Angeles, what are some of your thoughts in regards to?
Well, one of my colleagues, who I'm on another group that we have, is Kanwal Koreja, who's trained in ISTDP, and his background is from India. He's a Sikh, and we've had a number of discussions on culture. And also Salman Akhtar has spoken fantastically, and he spoke recently in Toronto. Well, it was Zoomed, but it was, and I'd heard him speak before. So he is one of the most interesting people, I think, in talking about culture. I find a lot of what's written about cultural impact is very superficial, and it's about understanding, some very instrumental things, but it's not getting to the core. And the core is really, is this model altogether relevant or not to certain cultures? And I'm thinking of, and that's a bigger question, of how relevant it is. The issue of culture in psychiatry is, and in all other healthcare, has blown wide open, largely because of what has happened in the United States in the last few years under the previous administration, where racism sort of came out from under the stones and astonished people, the extent of it. I mean, it was just not known, I think, even to Americans. Anyway, So it's a big issue, and every program, every department has come up with strategies for dealing with discrimination and also the relevance of psychotherapy for some of these things. And for many of the problems that we have, it has little relevance. The problems are in socioeconomic determinants of health and outright racism and things like that. So I haven't written a book on the relevance of culture, psychodynamic relevance of culture, but the best I've come across is Salman Akhtar, and he's come in as an analyst, strict analyst, but he has a very subtle understanding of culture, which goes beyond the superficial surface. It goes into what are intrapsychic conflicts and what are cultural conflicts. And the cultural conflicts comes when you move from one culture to another, as he did from India to the United States at a late stage of his life. And there are so many intrinsic conflicts that are very, for example, he talks about taking a taxi ride with somebody and do you offer to pay? Now, that would be unheard of in his culture, but something that in North America is done, not done in Ireland either, or to offer to pay for gas, that would be rude. And very subtle things like that would totally pervade the therapeutic frame. He talked about a Japanese patient who wouldn't enter the room unless he sort of bowed twice. That would be impolite. And his thing is, do I modify my frame, he's an analyst, to accommodate this? Or is the other person expected to conform with the new culture? And his view was that you accommodate to the person's culture and these sort of things where they're not interfering. So yes, all of these things are huge, but I'm not, I haven't written on it other than publishing a brief review of Akhtar's work in I have my own journal. It's a good way to get published. I have my journal. It's called the Journal of Psychiatry Reform. If anybody wants to write an article, actually, it's really a blog, but it's styled in the form of a journal, and we do have an editorial board, and we're not indexed. But if anybody wants to write articles on this topic or any other topic, and we're only looking for 800 to 1,500 words. It doesn't have to be long because people's attention span nowadays is very short. And I circulate the links by email and on Twitter and things like that to get them circulated.
Alan, can you send all of those links to us? Because what we will do is ship it to the IEDTA and CEPI, two organizations that would really support your work.
If you look at my email, you'll see 3 links on the bottom.
Okay.
One is to the Springer edition of the book. One is to the Journal of Psychiatry Reform. And the other is to my YouTube channel, which I just set up in the last few weeks. We did 2 short videos, 6 minutes, 4 to 6 minutes. And because that's the attention span that I'm aiming at. And that's another thing that I'm using to teach. Yeah.
We'll link it up to the affect phobia therapy website too, so that people can find you that way too.
And I just wanted to say shout out to Sunya. I did get your email. Thanks for sending it. I'll reply.
Any other comments, questions? Hi, Stanley Messer, who I had dinner with in Dublin, by the way, a long time ago with Brigitte. So that was a great dinner.
Oh, someone's asked the name. It's Salman. Sorry, somebody asked the name for the cultural right. Salman, Salmann. Akhtar, Akhtar. And he said for the first 20 years in the US, he never corrected other people who mispronounced his name as it's Salman, not Salman. And that's showing the impact of culture even at that level of how we feel about ourselves and how we relate to the other and his colleagues as well. And, yeah. Sorry, somebody was.
I think Stanley Messer, I was hoping he was going to say something. Hi, Stanley.
I have a lot of things to say, but I know that time is very short. So
No,
let me.
we're going over.
Yeah, so a few comments. First of all, I don't regard psychoanalytic therapy as non-affective, by the way. It's not only short-term dynamic therapy, that is, but the way I was trained by people like Bob Langs and others back in the early 70s, there was an emphasis on affect. Although, of course, I understand, particularly in the kind of confrontation that in the ISTDP mode, that it is probably more so. I would also say that psychoanalytic therapy is empirically supported. So I don't think we should make a differentiation on that basis between that approach and the attachment approaches, for example. Even granted that there are a lot of research in the attachment area, there's now quite a lot of research, as I'm sure you're aware, of psychoanalytic therapy and its effectiveness. And as to the question, what I would ask is, do you think it is the common factors that really matter when it comes to outcomes? Or is it all the differences that still exist between these therapies that matter and that each in its own way can lead to a good outcome, an effective therapy?
I don't know the answer. You know, the dodo effect, you know, all are winners and all shall have prizes. You know, the idea, if you look at the literature, you can look at the literature that compares all the main modalities. I think it's Kupfer from Denmark, no, the Netherlands, who's done a lot of that work. And you can either read all the empirical literature and say nothing works, or you can read all the empirical literature and say everything works. The methodology in, not just in psychotherapy, but in the whole of medicine now, is very difficult to make out. It's become so complicated with network meta-analysis and all the rest of it. quite a lot of it is not valid, but I think there's enough empirical support for the therapies that have been mentioned. I'm aware of Ring's work in long-term studies, and they've done good work in Germany. But I don't know which therapies work best for whom and by whom. And I think it's very hard to determine that. There are too many variables. Certainly the common elements are very, very important. I think ISTTP may have some specific elements that are different from the other two, even though I've compared them. But they do have some other elements which may or may not be critical to their model. I think they adhere to their model much more strictly, you know, and whether that makes a difference in outcome, I don't know. So I can't answer your question, but thank you for your comments.
Thanks, Dan.
I want to say something about that differences. You know, the more I'm looking at different models, I think I would like to use different models depend on the developmental stage of my clients. Like the early, like 0 to 18 months, I think EFT with a lot more encouraging dependency or not shaming the dependency, that works best. ISCDP is like a little higher developmental model. I mean, will structure is so important. So that's a little older child's issues, and like 3 to 5 or something, the will structure. So that's what I find important, to knowing where is this person developmentally, and that with different kinds of therapies.
So, go ahead, Alan. I want to say something, but
yeah, go ahead.
I mean, I'm so glad that you said that, because I started as a child adolescent therapist, And so when I would meet with children, all my interventions were based on where were they developmentally. I mean, that was the only way to work with them, like play therapy. Like, I mean, there's a whole assessment process. And I have found that when I've worked with adults with significant like childhood trauma, I just go back to working in that way. And I'm so glad that you mentioned that. So because I think these days I just kind of do it without thinking so much, you know, but I do that too. So
yeah, that's not something that's talked about a lot in this, you know, EDT models. But I
yeah,
think
I was embarrassed to talk about it. Yeah. Yeah. So
Yes,
thank you.
the idea of trying to figure out where the person is at and what signals they're giving you and how to respond to guide your interventions is a very interesting idea. And I'm not sure I've mastered it. You know, I think some patients are very difficult. The more severely ill personality disorders, it may not be. You know, you just as an onslaught of attack. You know, I think you have to switch to DBT or something. You're just at that level. There's if there's a very severe damage, early developmental damage. Yeah. So the developmental perspective, yeah, it's interesting.
Well, Alan, you've been with us for an hour and a half now. I know it's nighttime where you are, and it is for many people who are on this call. Like,
Oh yeah.
I'm just beginning my day in San Diego, so you know, I could see how night's falling in different places. Does anyone have a last question before we wrap up for today?
Can I ask a question, Kristin?
Yeah, I'd love that.
Alan, first of all, both Alan and Kristin, thank you very much for this really wonderful presentation today. Alan, you said I don't know which therapy works best with which clients and which problems. And still, if you are a therapist, I am one, but there are many who have experienced and have learned different approaches, and we meet a new client. What might help us, nevertheless, to know what might be, or how can we arrive at a decision which therapist to offer if we have different possibilities in ourselves?
Right. If you have the capacity, I mean, I will use other modalities, bits and pieces. I think we can integrate bits and pieces. I think we can integrate them, but that goes back to the question is, should you stay within your own model? Because is it the specific model that works rather than mixing stuff in from other models? Although I think probably the non-specific factors are still very strong. So you can switch. I mean, I think the biggest problem is that, yeah, I could do cognitive therapy, but I don't want to do it. So I will refer to somebody else. I'm not fully trained, but I use a little bit for my general psychiatric work. You know, people coming in with very severe depression, I will use a bit of cognitive therapy about distorted thoughts and so on, because it gives them some hope when they're profoundly depressed. So you can use different things. I'm sure my cognitive colleagues would be upset because my level of training isn't at their level, but it does help patients. So yes, but there is a problem that we like to do what we're biased towards what we're most trained in, and can we be objective and enough? I work in a clinic where cognitive therapy is the main thing. In fact, it's very unusual to find psychiatrists working in a hospital doing psychodynamic therapy. And I'm working in an anxiety clinic, and I work with people who don't have primarily anxiety, they have everything else, you know. So I'm an imposter, but I'm accepted because I will deal with the patients that don't respond to CBT. The patients that do best, yeah, it's a big topic, but there are some patients I think who do well with CBT. I would say certain anxiety disorders, early stages of trauma. OCD, for example, is one. Now, if you go to affect phobia therapy, the manual by Lee and others, they have very extensive criteria for selection, which is really useful. In my book, it's just the barest outline of who might be a good candidate. But as far as treatment outcome, yeah, there's such a vast literature, I can't really summarize it. But I'd like to hear from you maybe how you do it, but we're out of time, I guess, but that would be interesting.
I want to just say a real quick thing. I mean, what I do is very, very simple. It's really assessment. Where's the person on the triangle? And the minute I identify where they are on the triangle, it's like I have a menu that drops down of different interventions that I can use. And and the theory, I mean, of course, affect's just integrated inside of me I mean, it's just in me now. So it's always like, is this person connected with themselves? Are they connected with me? Right. And if they're not connected with themselves, right, therefore they're not connected with me. Where are they in the triangle? Are they on the anxiety pole or the defense pole? And then once I identify where they are, right, the menu drops, and then I just go, am I going to do motivational interview in this moment? Am I going to do classic CBT? You know, am I going to do a little sensory motor on the feeling pole? Like, I mean, I really allow myself to play with what makes sense with the person, and I try to make the interventions as simple as possible. So, you know, so that's what I do.
Very
Thank
good.
you for the useful comment. You said you would want to know how I do it. I remember I was trained as a cognitive behavior therapist for many years. And then suddenly I found that I was very often very successful when I did not do CBT, and I didn't know exactly what I was doing. I was doing something different. And then slowly but gradually, I learned that there were other approaches. And nowadays, I must confess that when I'm seeing patients, I don't know why I am reacting in a certain way in the session itself. After the session, I might analyze and etc. But the truth is, in the session, I'm there and I don't know really why I'm reacting the way I'm doing.
Well, and Alan, I've seen one of your videos long time ago. I don't know if you remember. And he has this very kind of wise way about him that's also playful. So he goes from like, he just that wise persona and then the ability to be playful in the moment. So I remember thinking everyone probably has a really nice time doing therapy with you.
Well, that's
Thank you.
Humor is another interesting thing, the use of humor, which is very little covered. I have a couple of pages in the book, but because I use an awful lot of humor, which can be helpful but can also backfire.
Yeah.
I hope I didn't backfire today.
You were fantastic. And, you know, Jaak Panksepp came to the IEDTA conference in Vancouver in 2010. And wow, his work and playfulness, I mean, it is
oh, yes. Yeah.
really, I think the most healing affect is playfulness. So
yeah, he's very good.
Yeah.
He's wonderful.
But thank you so much, Alan.
Okay.
I went way overboard. I did a good job telling people, oh, they can leave, but I really love listening to you and your perspective, and it was just a joy to have you. I hope you come back again.
Yeah, well, thanks for having me. It's been wonderful, and it's great to meet all of you. I love to talk more. I want to get to some of the conferences after all this lockdown is over. Yeah,
we'd love to see you there. So thank you. Bye, everyone. I miss you already. So.